3 announcements. First is to remind you that the next seminar in the Women's Health Series is on February 19th, and it is a lecture by Dr. Casamano. Second assignment from Macau is to remind you to please fill out this form. And then my third assignment is to also let you know that Dr. Fort is giving volunteers to give a second seminar tomorrow at 4 o'clock. Hopefully you got that flyer along with this announcement. And the title of the seminar tomorrow is Novel Factors That Influence Musculoskeletal Adaptations to Exercise. So with that, I'd like to first introduce myself. My name is Dawn Lau. I'm an associate professor in the program of physical therapy that sits within the Department of Physical Medicine and Rehabilitation in the medical school. And I am pleased to have been able to invite Dr. Fort as the recipient of the Center on Aging's Kessler Lambert Chair in Aging Study. And with that chair, I had proposed to interface with the Powell Center to promote aging and women's health. And part of that is to be able to invite speakers such as Dr. Ford. So I would like to thank the Center on Aging and the staff for helping put this together, and then also the Powell Center on Women's Health, Dr. Raymond and Dr. Ryan for supporting this activity. Now to introduce Dr. Ford. It's always risky to invite a speaker from Minnesota in January or February, but I knew I was okay when we were exchanging emails, and she's one of those that replies to emails really fast. And there was one exchange where there was about 1 day delay, and then she told me she was in Wisconsin at a Green Bay Packers game. So I didn't hold that against her, but I knew, okay, we're okay inviting her to Minnesota in late January, we're just fine. So Dr. Ford is a Wisconsin native. She did her undergraduate work in Wisconsin, received her PhD, earned her PhD, I like to say to students, you don't receive a PhD, you earn it, at the University of Arizona State, and studied exercise physiology. She began her research career at the University of Washington in St. Louis, where she did research on exercise and hormone replacement therapy to prevent diseases such as diabetes and osteoporosis. In 1999, she moved to the University of Colorado in Denver. And from there, I could talk about her accomplishments for a long time, but don't want to take away from your time to share your research, so I'll just highlight a few things. She is the director and established, in fact, the IMAGE group. So the IMAGE stands for Investigation in Metabolism, Aging, Gender, and Exercise. So it was fun to promote her seminars to very many different groups at the University of Minnesota because she spans such a wide area. She's a professor of medicine, a member of the Center for Women's Health, and also a member of the Rehabilitation Science Graduate Program. She's in the Division of Geriatric Medicine in the Anschutz Medical Center. She's chair and scientific advisory of the Adult Clinical and Translational Research Center, director of a lab who is supported by several R01s, and co-director, co-investigator of many additional R01s. So we welcome Dr. Fort and her vast accomplishments, experience, expertise, and thank you for sharing that with us today and tomorrow.
Thank you very much, Dawn. Can everybody hear me up in the back? Good. Thank you very much for the signal. It's really a pleasure to be here visiting the land of 10,000 ice rinks. I did grow up right outside of Green Bay, so I knew what I was getting into, but I thought earlier this month when you had your stretch of deep freeze that I was home free, that certainly you would not have 2 spells of sub-zero weather, so I really wasn't expecting it, but it's okay, I'll survive. I want to talk primarily about the regulation of physical activity and bioenergetics by estrogens today. I'll expand on that a little bit, but since Dawn brought me in, both because of her connections with the Women's Center and the Aging Center, I thought I would start out by showing, from my perspective, because this kind of guides how I do my research, how I think of aging. So in your heads right now, I guess I'll use the mouse here as a pointer, if I can get it to work. What I have on the y-axis is functional reserve, and this could be any biological system, musculoskeletal, cardiovascular, whatever, going from low to high, and then along the x-axis, going from young adult up to elderly. So in your head, if you had a picture of what you would like ideal aging to look like, what would it be for this relationship between function and age? It would be exactly a square wave, where we would maintain our highest level of function until the day we died, and that would be it. Now, unless you meet with an early demise, this is certainly not what most of us experience. So we should shoot for successful aging. And successful aging probably looks something like this, where we can maintain our peak level of function well into our adult years. And I really think we should be able to maintain function in most systems up to the age of about 50 with appropriate lifestyle. Then there's going to start being a slow, inevitable decline in function. And then there seems to be another pivot point, a hinge point somewhere out there, maybe around age 75 or 80, where the slope of the curve gets a little slipperier and functional decline accelerates. So most of you looking in the audience are probably of the age where you've seen this in your grandparents. Some of you, maybe your parents. I know I certainly saw it in my father, who lived long enough to see that every time I saw him, with only a few weeks or a few months in between, there was noticeable decline in his functional abilities. Now, many of us in this country and other technologically advanced countries don't even achieve what I have referred to as successful aging. Many of us experience usual aging. And now it's not just the effect of aging per se, that inevitable change that we experience, but an acceleration of the loss of function by other factors such as disease, obesity, physical inactivity, or environmental toxins like smoking or exposure to radiation, sunlight. And I think what's really scary in this country today is that some of our youngest generations are not even achieving their highest level of function, probably because of obesity and the sedentary lifestyle that's become pervasive in technologically advanced countries. So they not only never achieve their peak level of function, because they experience the decline that we would get even with usual aging or successful aging, they're going to experience, if there is such thing as a threshold level of function that we need to maintain, they're going to get to that threshold earlier. So it has a negative impact on the individual's quality of health, but also has a major negative impact on our healthcare system. So I've talked about successful aging versus usual aging, and these can also be described sometimes as primary aging or secondary aging. So primary aging is going to happen regardless of what we try to do to stop it, but secondary aging is thought to be at least modifiable. So let me give you just a couple of examples of things that fall into these two bins. We know that with advancing age, maximal heart rate decreases. It doesn't matter if you're physically active or sedentary, it decreases. And in fact, we use age to predict maximal heart rate, 220 minus age. So that's something that is a primary aging phenomenon. Something like the loss of reading vision. By age 60, 99% of individuals will have presbyopia because of age-related changes in the eye. I've got a month and a half to make it to the top 1%. That is a primary consequence of aging. Menopause is an age-triggered event. The loss of reproductive function, the loss of gonadal function, is an age-triggered event. Nothing we do can prevent that, so that is a primary consequence of aging. But something like the loss of muscle and bone mass, I would put into both camps, because there's certainly an inevitable component to that, but we know that people who are very sedentary will lose muscle and bone just because of their lifestyle. And then something like the decrease in physical activity. I would put that, and I have long put that, into the modifiable category. But I'm actually going to show you some data today to suggest that perhaps there is an inevitable consequence of aging that has an impact on our physical activity levels. So the working model that drives at least part of my lab is that we don't age as one body. Different systems within our body age at different rates. So the example that I'm going to use here is that the loss of gonadal function, the aging of the ovary in women, will have an impact on other systems that could increase risk for disease. And I think this is more important in women because we lose gonadal function. Our ovaries become aged at a relatively young age. Average age of menopause is 51. We know far less about reproductive aging in men, but we know they maintain their reproductive abilities to a much older age. So it's probably at least 20 years later that they lose their reproductive function. So I don't know if you buy into this system, but I can tell you that we have one excellent example of this in operation. So we know at the time of menopause, the loss of estradiol causes women to start losing bone at a very accelerated rate. And this increases their risk for osteoporosis. So here's a situation where the aging of the ovary has a systemic effect that influences disease risk. And we know a lot about this process. We know that giving estrogen will delay the loss of bone until other age-related factors start kicking in and cause a decline. But I think the question is whether the loss of gonadal function also affects other tissues. We have some hints that estrogen is important for preventing dementia, possibly, or things like osteoarthritis and many other things. But it could also have a more systemic effect on something like energy balance and the propensity to gain fat that could influence risk for all obesity-related diseases. So I'm going to show you a little bit of evidence for this. And then finally, the more novel aspect of this that I want to get to is that work by outstanding scientists like Dr. Lau and others have demonstrated that gonadal hormones regulate spontaneous physical activity. And if this is true in humans, that the loss of gonadal function causes us to move less, because there are so many benefits of physical activity on multiple aspects of health, I would expect that to have a very encompassing effect to increase the risk for many of the chronic diseases of aging. So here are the three areas that I want to touch on in my lecture today. And if you have questions as I go through any of this, don't hesitate to interrupt as we go. I'm going to first talk about some work on vascular endothelial function that a colleague of mine, Carrie Moreau, does in our research group. Then I'm going to talk about the role of estrogen in regulating body composition and fat distribution. And then finally, I'm going to get on the topic of physical activity and bioenergetics. So Carrie's just completed is finishing her first R01, where she has characterized changes in vascular function in women across the menopausal transition. So she enrolled about 140 women and categorized them as premenopausal, or early peri, late peri, early post, or late postmenopausal. And then measured their vascular endothelial function by flow-mediated dilation. And you can see this stepped decline in vascular function based on these cross-sectional data as women transition through the menopause. And I just want to bring your attention to the average age in these groups. So that for these three groups, average age is very similar, but yet we see changes in vascular function. Now, one of the things that she did to try to isolate age from menopausal status is to put these women on a drug, a gonadotropin-releasing hormone antagonist that suppresses gonadal function. It does this in both men and women, so in this case, she's suppressing ovarian function essentially to postmenopausal levels. And when she does that and then measures vascular function again, you can see that the biggest decrease in vascular function occurs in the group whose reproductive robustness is best, the premenopausal group. And as you go through the menopause transition stages, the effect of suppressing ovarian function diminishes. So in the next slide, I'm just combining the two slides that I just showed you, where the darker colored blue bars are now the level of vascular function after ovarian function has been suppressed. So you've taken away the effects of estrogen in this model, and now you're looking at age-related differences, which are much more minimal, suggesting that these changes in vascular function across the menopause are truly related to factors associated with the menopausal transition and probably estrogen levels, and not simply to the aging process. She is also doing very extensive studies, this is just one of them, to try to isolate the mechanisms by which estrogen influences vascular function in women. And in this one, she does an experiment where she measures the flow-mediated dilation in the basal state, then waits a short period of time, and starts an intravenous infusion of ascorbic acid, or vitamin C. Vitamin C is known to be a potent antioxidant when the levels are very high. So this is a pharmacologic dose, not a physiologic dose of vitamin C, and it's nothing you could ever get to by just popping vitamin C pills. But this is a model that in animals has been demonstrated to reduce the level of oxidative stress. So when she gives these women this intravenous infusion of vitamin C, now in the dark bars, their level of vascular function, at least in these three groups, comes back up to the level of normal in early perimenopausal women. Not quite to the level of premenopausal women, but just acutely adjusting or mitigating oxidative stress repairs or normalizes vascular function in these middle-aged and older women. So this suggests that the decline in vascular function with estrogen deficiency is related to an oxidative stress mechanism that is reversible. So that's kind of our overview of a system whereby we are getting more evidence that it is menopause per se and not age that influences the decline in vascular function. That is a predictor of cardiovascular disease risk. So now we've got additional evidence that menopause may increase risk for disease. So let's go on to body composition and fat distribution. I think the prevailing question here is whether menopause, again, menopause and not aging, triggers an increase in fat accrual or a change in where we store our fat. Because we know before menopause, women tend to put on their excess fat in their hips and thighs. They're really protected against putting on fat in the intra-abdominal region. Now, men start putting on fat preferentially in the abdominal region from a young adult age. In fact, if you see a guy with a stereotypic beer belly, if you tried to pinch the fat under the skin, there would be very little there. That fat that's causing the abdominal wall to protrude is actually stored behind the muscle wall in around the visceral organs. And it's fat in that region that is thought to be more harmful on health than subcutaneous fat because of its location around the visceral organs. And young women, unless they're very obese, really have very little intra-abdominal or visceral fat. Women tend to store their fat subcutaneously until they go through menopause. But is it an effect of menopause, or would we see this with aging, independent of menopause? So we have evidence from various types of research. We have some cross-sectional comparisons, some responses to the suppression of ovarian function, and then effects of postmenopausal hormone therapy. So let me just go through some of the data to support this phenomenon from these types of evidence. This is a cross-sectional study. It comes from an Italian group. I think there are over 2,000 women represented in this slide, where they measured body composition by DEXA, dual X-ray absorptiometry. And that instrument allows you to look at regional fat mass in the arms, the legs, and then the trunk region. And what you can see when they categorize their women as being premenopausal, perimenopausal, and then postmenopausal, not on hormone therapy or on estrogen-based hormone therapy, it suggests that with advancing transition through menopause from pre to post, that there is potentially a decrease in lower extremity fat, the legs, and an increase in upper body fat, and predominantly in the trunk region. And yet, at least in this cross-sectional study, the women who were on estrogen-based hormone therapy, so the darkest blue bar here, that increase seemed to be prevented. So here's at least suggestive evidence that estrogen-based therapy might prevent menopause-related changes in how we store our fat. Better empirical evidence comes from these studies where they have suppressed ovarian function with a similar drug to the one I mentioned that Carrie used. This is a gonadotropin agonist that's used to suppress ovarian function more chronically. So this is a drug that's used to treat endometriosis and uterine fibroids. It's usually administered anywhere from 4 to 6 months to suppress ovarian function to the level of a postmenopausal woman. So this was a study that used 4 months of therapy and measured changes in mass, fat mass, total fat mass, trunk fat mass, and then the arm and leg region. And you can see an increase of just over a kilogram over this period of time. That's 2.2 pounds of fat that was gained over 4 months of the suppression of ovarian function. That's an energy equivalent, I don't know if it's going to come up on here or not, that's an energy equivalent of almost 100 kcals, 100 calories a day of energy balance being disrupted. So this isn't a small impact on metabolism, it's a pretty pronounced impact. And to look at if there was a change in where fat was being stored, they looked at the ratio between trunk fat and leg fat. And if fat was being stored proportionally in the same places, that ratio should have stayed the same. But in fact, the ratio went up at the end of therapy, indicating that a greater proportion of fat was being stored in the trunk region compared to the leg region. Now this slide shows you all the studies that I'm aware of that have measured changes in body composition in response to this drug treatment, gonadotropin-releasing hormone agonist therapy. So down on the bottom, you can see that some of these studies were very small, n's of only 6 or 10. But now at the bottom here, I've indicated the duration of therapy, going for anywhere from 2 to 6 months. The red bars indicate the change in fat mass that was measured. So anywhere from about half a kilogram up to 2 kilograms, that's 5 pounds of fat gain with 6 months of ovarian suppression. And if you look across all those red bars, the average disruption in energy balance to generate that increase in fat mass is in the neighborhood of about 80 kilocalories per day. So that's how energy balance is disrupted when we suppress ovarian function. The blue bars are something that people don't really appreciate. When women go through menopause, we know they have an accelerated loss of bone, but we think they also have an accelerated loss of muscle, something that Dawn is very interested in. And this study demonstrates that it's not a true measure of muscle mass, but it's the measurement of fat-free mass, which is vital organs and muscle mass. These studies also demonstrate that there is this triggered loss of lean mass that occurs when we suppress ovarian function. And that's been observed in all of these studies with the exception of one. This was a slide that I put together for a grant application just to demonstrate that there's a lot of evidence that hormone therapy in postmenopausal women regulates propensity for weight gain. I think a lot of women believe that hormone therapy causes weight gain, but all of these studies, which on the left side of the slide, these are some of the big randomized controlled trials of hormone therapy, including the Women's Health Initiative, the Heart Estrogen Replacement Study, the HERS trial, the PEPI trial, the HOPE trial. All of those, plus some smaller physiologic studies on the right side, all demonstrate that when you're doing a controlled trial, it is the women on placebo therapy or no hormone therapy who have the greatest gains in body weight. And it's actually the women on hormone therapy, most of them are still gaining weight, but the rate of weight gain is attenuated by about 40%. But this evidence is not consistent. So there are people who believe that estrogen does not have this effect. So this is a quote that I took out from this review paper by some of the SWAN investigators. SWAN is the study of women's health across the nation. It's a prospective longitudinal study where they're following women as they go through the menopause transition, bringing them in for annual visits. And what they stated in this review article was that although the published literature is quite convincing of an effect of obesity on the magnitude of menopause-associated hormonal changes, obesity on hormone changes, it does not clearly support a relationship in the opposite direction, namely an effect of the menopause transition or its associated hormonal changes on either overall weight gain or central distribution of body fat. So they're saying that the evidence that I've shown you in the previous slides really doesn't exist, I think. And their information comes from very solid research. So these are some of the results from the SWAN study where women come in for annual visits. They start when they're still premenopausal. When they have the visit that is closest to their last menstrual cycle, the final menstrual period, that gets identified in these charts as 0. So we're looking at changes that precede the menopause transition and follow the menopause. And what you're looking at here in the top panel is the change in waist size, and in the bottom panel it's the change in fat mass. Now when you look at that, there's no obvious effect of the menopause. These are, with the exception of a few bumps, they're essentially linear changes in these two parameters. But because of the very strong and inextricable association of the menopause with age, it's very challenging to try to dissociate what is triggering these changes. Is it an aging effect or is it a menopause effect? And when factors change essentially linearly, as they do in this data set from before to after the final menstrual period, the conclusion, at least of these investigators, is that this is something that's happening because of aging, not because of the menopause transition. But I want to take a theoretical step back from this. I actually started out as an undergrad as a mathematician, so I'm intrigued by numbers and patterns of change and those sorts of things. And my concern is that we know that the menopause is a process, not an event. And it's a process that can take place over years, not months. But we we know very little about the average duration of time a woman is in the menopausal transition or the patterns of change that occur during that transition. So in theory, there might be women who start menopause-related changes 3 or more years before their final menstrual period, and they might have faster changes early that tend to then slow down. But there might also be women who don't have much change in whatever outcome you're interested in until shortly before their final menstrual period. So they have more accelerated changes closer to their time of menopause. And the problem is when you just lump everything together in this theoretical example I've used, if you take the average at each one of those time points, you come up with a perfectly linear line. So my concern is that our failure to account for individual variability in the duration or pattern of change across the menopause transition could be obscuring our ability to identify menopause-related changes. So I think where we are currently with our knowledge of body composition is that we know women and men get fatter with age. We still do not know why. My professional bias is that estrogen is a potent mitigator of body composition, and I'll show you more evidence for that in the next step. Steve?
Yeah. Has anybody studied the women who have had their ovaries removed due to either cancer or fear of cancer and don't comply with taking estrogen replacement?
Yeah, so women who've undergone oophorectomy, there are not many published papers of them. It would be a very unique group to study. The few papers that are out there do demonstrate that they have, most of them have been within the first year after surgery. They have changes in body composition and in other clinical outcomes like insulin action, glucose tolerance, lipid changes that are all consistent with them moving toward being metabolic syndrome-like. So increased accumulation of trunk fat, more insulin resistance, lower HDLs, higher LDL, the whole package.
Is that kind of attenuated in the ones who do go on?
On estrogen, there have been fewer studies of the oophorectomized patient populations that have looked at that. I think some of that comes out of the Women's Health Initiative trials that have looked at estrogen plus progesterone versus estrogen only. So those two cohorts were different in that the estrogen only group had a hysterectomy. They didn't need to take progesterone. And if you looked at those two cohorts as baseline of the Women's Health Initiative trials, so women who had not had estrogen for a longer period of time because of hysterectomy, they looked worse than the other cohort. And there are some differential responses to the two different types of treatment. I don't have those slides in here today, but not many. So let's move on to talking about what I said that by the title of the talk I was going to be focusing on today. And this is an area that I've moved into recently in my lab because there's certainly a literature that goes back many years in the animal world to study this. But in the last 10 years, it's really been a burgeoning of this research that is all very consistent. And what I like to do in my lab is determine whether these studies at the bench have any clinical relevance in humans. So this is a study that looked at the bioenergetics of ovarectomy in mice and rats. You're going to see a few slides following this same paradigm. So after surgery, we're looking at body weight here. You can see that the surgery causes a decrease in weight, and this is either a surgery where the ovaries are removed, those are the blue lines, or the surgery where everything happens but the ovaries remain in place, so it's a sham surgery. So the animals recover from their surgery, and then in the ovarectomized groups, both mice and rats, you see this very accelerated rate of weight gain. And in the labs that have tried to look at this from a system level mechanism perspective, they're looking at whether it's the energy intake or the energy expenditure side of the balance that is affected. And here we see some species differences. This is energy intake in mice and rats. You can see that the mice who have this surgery come right back up to their pre-surgery level of energy intake, and it's no difference between the sham and OVX groups. But rats, on the other hand, as soon as they recover their surgery, the overectomized animals are eating 30% more than the sham-operated animals, and that level of energy intake then persists. But it isn't just energy intake that is the key, because in this study, you see the differences here in weight gain between OVX and libidin-fed animals and sham animals. But when these investigators pair-fed the overectomized animals with the sham animals, so they gave them exactly the same amount of food, the overectomized animals still gain more weight. So that means if it isn't the energy intake side of the balance that explains everything, it must be the energy expenditure side that contributes to this. And in fact, it does in both species in this study. That in mice after surgery, you could see that the overectomized group never gets back up to the level of activity as the sham group. So their level of activity is reduced by about a third. And the rats look like they're struggling to recover, and at some point they just say the heck with it, and they start declining also. So I hope everybody on this campus has seen this slide, because it's from Dawn's lab, and I use this in all of my talks on this because it has such a profound impact on how I think about this problem. So these are animals that were put in cages that have running wheels, and you can see the top line, the sham-operated animals, are very, very active. They're running about 10 kilometers a day in their little running wheels. But the two lines down on the bottom, where you almost can't see them because they're so low, these are the overectomized animals, where their spontaneous activity, how much they got into their running wheels to move, was decreased anywhere from 60 to 90%. And then Dawn looked at different ovarian hormones to see what effect they have. So if she gave these animals back progesterone, it had absolutely no effect on their running behavior. But animals that get back estradiol have essentially a full rescue of their activity phenotype. So this is very compelling evidence that estrogen levels regulate behavior, movement behavior in animals. But it isn't just that may disrupt energy balance. This study, down in the lower left corner, you see accelerometry data, same sort of little accelerometers that we use in humans to see how much humans are moving. They did this in these animals. That's summarized in the lower right-hand corner and summarized over the light and dark cycle. So you can see during the light cycle, when animals don't typically move very much, there was no difference in the level of movement between the sham and OVX groups. But this group also measured oxygen consumption as a measure of metabolic rate. And even though activity levels were not different, the OVX animals still had a lower rate of oxygen consumption, suggesting that the loss of ovarian function can disrupt energy balance both by making animals less active and by reducing their rate of metabolism. This doesn't happen only in females. It happens also in male animals. So this is a study from Tim Lightfoot's lab at baseline. This is also real running activity. He had 3 groups, not different at baseline. 2 of the groups then went through orchiectomy, so decreased their testosterone levels to castrate the levels. And you can see that their spontaneous activity levels plummeted about 70%, just similar to what we see in females. And then when he added back hormones Adding back estradiol got about a 50% rescue. Adding back testosterone got a full rescue. So you might suspect that both testosterone and estrogens are important in male animals, but in fact, when he blocked the conversion of testosterone to estrogen using an aromatase inhibitor in the male animals, the blue bar is that aromatase treated group still had a full rescue. So it suggests that only testosterone is necessary in male mice. I've already showed you some slides to demonstrate how females gain body weight on the left side and gain fat on the right side. Life is not fair because even though the males have the same decrease in physical activity, they don't have these same increases in fat mass and body mass. In fact, the males lose weight and lose fat when they get orchiectomized. So we're just going to summarize several studies on this. The effects of ovarectomy in females are to decrease physical activity, increase energy intake, decrease metabolic rate, increase abdominal fat gain, and metabolic dysfunction, including insulin resistance and dyslipidemia. In males, the effect of orchiectomy is to decrease physical activity, and none of the rest of that phenotypic consequence. And I don't have any evidence to show the second part of this, but I've already showed you that these changes can be prevented or reversed with estradiol or testosterone treatment, but they can also be prevented by programming exercise. So the animals won't exercise under their own volition, but if you put them on a treadmill and force them to exercise, you can prevent the metabolic dysfunction. But so what? We don't care what happens in rats and mice, so maybe some of you care in your labs, but we really want to know what happens in humans. And there have been these studies following women through the menopause transition, but most of them have only used pencil and paper questionnaires about how active you are. And I don't think that's going to be sensitive enough to pick up any changes. But there was one of these prospective cohort studies conducted at the Pennington Biomedical Research Institute down in Baton Rouge that used objective measures of physical activity. So they used accelerometers once a year. So this is the same sort of slide that I showed you earlier, where 0 is the study visit closest to the final menstrual period. So this is when women became postmenopausal. And in this series of slides that I'm going to show you, that 0 year is always set to 100%. So you're looking at relative changes here in weight leading up to the final menstrual period and after the final menstrual period. So in terms of body weight and relative adiposity, you can see that there is a small increase in the years leading up to menopause, but really not much change after that point in time. They also have CT measurements of the abdominal area to look at the changes in visceral or intra-abdominal fat or subcutaneous fat levels. You can see that both are increasing. Again, the biggest changes occurring in the years before the final menstrual period, but the changes in visceral adiposity are really striking. So there does seem to be a midlife related increase in visceral adiposity in women. And then on this slide, I'm showing you their self-reported caloric intake data. So I think this is a 3-day food record that they used. And what is very striking, remember these women were gaining weight and gaining fat despite the fact that they reported decreasing their level of energy intake over those 4 years leading up to menopause. And this is going from 150% down to 100%. That means by self-report, they're reducing how much they are eating by 1/3. That's huge, and yet they're still gaining weight. And part of the reason that they may be gaining weight is because by this objective measurement, this accelerometry device, they are also becoming less physically active. So here, in the 4 years leading up to menopause, activity levels are going from 200% down to 100%. So a 50% decline in activity, which is very consistent with what has been observed in animals. But those are cross-sectional data. So we want to look at this from a more controlled experimental model. This was a pilot study we did a few years ago where we measured resting metabolic rate in women. So that's the light blue bars, big ones, and that is going along with the left axis here. So we measured these women in the mid-luteal phase of their menstrual cycles when both estrogen and progesterone levels are high. I can't get my pointer. There we go. Then we measured them in the early follicular phase where these inset bars are estrogen levels. Their estrogen levels are lower. And then we measured them again after 6 days of suppressing ovarian function with GnRH antagonist. So we show that metabolic rate decreases as estrogen levels decrease. And the magnitude of difference, I don't have that on here, the magnitude of difference at the extreme was about 70 kilocalories a day, exactly what other people have demonstrated. And the difference between the early follicular phase and the GnRH antagonist phase was about 40 kcals. So we have just completed an expanded study, so that was just acute, 6 days of ovarian suppression. We just finished a trial where we've looked at whether that occurs over chronic hormone suppression or chronic ovarian hormone suppression. So in this study, supported by the NIH, we enrolled women to go through 5 months of gonadotropin-releasing hormone agonist therapy and measured resting energy expenditure by a metabolic cart. But we also have the luxury at our institution of having a room calorimeter, a 10 by 10 foot room where we can have women come in, or men, come in and spend the night and measure total energy expenditure. So that's the TEE that you're seeing. So these aren't the final data because we actually somehow were able to enroll 70 women into this trial. It was extremely difficult to recruit for, but I have an amazing research staff that does this. So these are some intermediate data demonstrating that at baseline, the women who were randomized to GnRH agonist alone, placebo add back, or getting back estradiol via transdermal estrogen therapy, at baseline, their resting and total energy expenditures were identical. Our hypothesis was that the placebo-treated group, so the group that only got their ovarian function suppressed, would have a decrease in their metabolic rate of 40 kcals a day because we did the baseline measurements in the early follicular phase. So in the previous slide, the difference between early follicular and suppressed was 40 kcals. In fact, their decrease was about 50 kcals. We projected that estrogen would prevent that, and in fact, it did. So we do see an effect of the loss of estrogen to decrease metabolic rate in women. Now, when I wrote the grant 5-6 years ago, I didn't know what I know now about the effect on physical activity. So I projected that the impact on total energy expenditure would just be what we saw with resting metabolic rate. In fact, the women who did not get estrogen added back, the effect of ovarian hormone suppression was to decrease total energy expenditure by 130 kcals a day. I would have projected that estrogen would prevent this, but in fact it has not. So the difference we see between the groups still seems to be only the effect on resting metabolic rate. But as an exploratory aim of this study, as an exercise scientist, what I'm really interested in is whether we can get women to exercise, hopefully before and after, but during their menopause transition to try to prevent some of these consequences. So we had a small group who got the placebo add back, but but then we added back programmed exercise coming into our facility. So they were doing about an hour a day of exercise 3 days a week. And I would have projected that this would maintain or increase metabolic rate, but it didn't. And I thought maybe this would be through the effects on lean mass. So we see a decrease in lean mass with ovarian hormone suppression that's prevented with exercise, but the exercise was not successful at causing the decrease in resting energy expenditure or total energy expenditure. Now in this study, even though we didn't have physical activity as an outcome because I wasn't aware of this effect, we did have them wear accelerometers for 1 week out of every month, starting before the intervention and then through the 5 months of intervention. So when we look at what we have referred to as spontaneous physical activity, these are not defined bouts. So they're activity that wouldn't meet the criterion of being a 10-minute bout, because we think a lot of that's going to be programmed into somebody's day. You park in the parking lot where I have to park, I've got to walk in, and it takes me about 10 minutes. So we wanted to look at all other activity. And in fact, even though we weren't expecting to look at this, we do see this discordance in activity levels that emerge starting after the second month of treatment, whereby the women who are getting back estrogen have higher levels of spontaneous physical activity than the women who are treated with placebo, those in whom their ovarian hormones are suppressed. And I'm just taking you back here to the slide that I showed you earlier. These are all the studies of gonadotropin-releasing hormone agonist therapy and changes in body composition. They're all pretty consistent. I'm going to add in our data. We did not see the phenotype on fat mass that we were expecting. And I'm not sure why. So I think I have underestimated the potential impact here of suppression, because I think these women were probably making dietary changes, because as part of our consenting process, we had to tell them that one of the risks was that they would gain weight and gain fat. And a lot of these other studies were in patient populations, so they were being treated with gonadotropin-releasing hormone agonists for endometriosis or uterine fibroids. So I think this is where we interjected at least the thought that they should be adopting some changes to prevent their increase in fat mass. But we're doing another one of these studies, so we'll get more evidence on this in a couple of years. So let me just wrap up here. In terms of what I showed you on gonadal function and vascular function, we have some very compelling cross-sectional data that support that the menopause transition causes a decline in vascular endothelial function, which would be projected to increase risk for cardiovascular disease. This seems to be specifically related to the loss of gonadal function, not a general aging effect, because of what we see when we suppress ovarian hormones. And at least now it's looking like ovarian hormones may preserve vascular function, specifically through minimizing the effects of oxidative stress. In terms of gonadal function and body composition, I showed you some preclinical studies in animals that provide compelling and indisputable evidence that the loss of ovarian function triggers excess fat gain in animals. And in some clinical studies, there is support for a menopause-related gain in fat that's particularly in the abdominal region, but this evidence is not consistent. And I've also shown you some evidence that menopausal hormone therapy attenuates weight gain, but again, that evidence is not consistent. And then finally, in terms of gonadal function and physical activity, in rodents, the loss of gonadal function generates this biological drive to become more sedentary. And at least some of the preliminary data that we have in humans suggests that that probably also does occur in women anyway. And if this does occur in humans, I think the compelling question is to what extent this influences disease risk, because we know for the major chronic diseases of aging, physical activity is an important mediating factor. And I think this is probably of greater concern in women than of men, both because the loss of gonadal function occurs at an earlier age in women, but also because of the observations in animals that the consequences of this are not as severe in male animals as in females. But I think the real question is why. You know, biology is supposed to make sense. Why, with the loss of gonadal function, should there be this biological signal to become sedentary? And that I don't have an answer for, but I'd be interested in hearing your opinions. And I just want to acknowledge my lab group, because they're the ones who do the work, and I get to come to sunny Minneapolis and talk about it. And I also want to acknowledge my supporters at the NIH. I've got support from aging, diabetes, and child and human development. Thanks very much. Any questions?
So I have a question. You actually alluded to it in the last slide about mood disorder. We know that women, as they move toward the menopausal transition, are likely to increase the risk of mood disorder. And there's some I don't know if there's controversy, but perhaps there's a lot of studies that have looked to see that menopausal transition actually is associated with greater likelihood of mood disorder. We know mood disorder has a consequence of decreasing physical activity. And I'm wondering to what extent you can tease that out from whether you can tease it out in animals or in the human studies that you've been looking at.
You know, I won't be the one to tease that out because it's not what I study, but I think you touched on what I think is probably the locus of these changes. I suspect they are CNS driven, and then if they are truly residing in CNS as the underlying mechanism, the systemic effects of that could be widespread. So is it a primary effect on whatever controls mood or motivation? I don't know, but I do think it's in the brain and not in muscle or anything else in terms of the regulation of physical activity. There's been some really intriguing work done by Debbie Clegg down at UT Southwestern, where she has manipulated estrogen receptor levels in various regions of the brain, and she can actually, depending on where she, I don't know if she's done overexpress or knocking down, she can independently create the hyperphagia phenotype, the overeating, or the hypokinesia, moving less, by manipulating estrogen receptors in the brain. So, I think mechanistically that's where the defect is. Now, if it's secondary to whatever region of the brain controls mood, I'm not sure, but I suspect they are intertwined.
It seems to me that your last question maybe we looked at a little bit more that when the animal's younger and reproducing, estrogen causes energy so they can do it all. Whereas when they're older, there's no need to have all this energy to run around taking care of the young and surviving. During evolution, most animals didn't live past the reproductive stage anyway. So you're not sure that looking at why we don't have physical activity with loss of hormones is the correct question.
Well, yeah, I think you can phrase it either way. And it's true that a lot of animal species do not live long beyond their natural menopause. And 100 years ago, neither did we. 110 or 120 years ago, the average lifespan was about 53, 54 years. So women were only living a couple of years after the menopause transition. But that's not true today, where women will live 30 to 40% of their lives after losing gonadal function. So I think it's a much more relevant question now, and understanding what the mechanism is. First of all, it doesn't really occur androgenism. There aren't good ways of treating that per se. So teasing out the effects of hyperandrogenism from hyperestrogenism is almost impossible. But I do think that from the studies that are being done more recently on treating postmenopausal women with androgens, that we see if androgens get too high, some of the same phenotypic characteristics that occur in PCOS. So I do think in that patient population, it's probably more the androgens that are driving their phenotype than the estrogens.
But most of that is from aromatization from their excess estrogen.
No. Aromatization goes the other way. T to E. Well, you can have some inner conversion, but not a lot. So in men, testosterone levels are 10 times higher than their estrogen levels. In women, it's much lower, but there isn't much conversion from E to T. Most of the T will come from adrenal androgens, DHEAs. That accounts for more than almost 100% of the androgens and estrogens in postmenopausal women. DHEA levels.
Thank you for the great question. We're totally another group waiting to come in.